Good morning and good afternoon, everyone. Why don't we just give folks a couple minutes to join, and then we'll get the session started. All right. Good morning and good afternoon, everyone. Thank you for joining us today for this special patient education webinar. My name is Henry Chang, and I have the honor of serving as the Executive Director of the Fatty Liver Foundation. Some of you might be expecting Wayne Eskridge, our President and co-founder, to welcome you today. I just would like to take a moment to share with you that Wayne has recently been diagnosed with multiple myeloma, and I think he shared this in one of his recent blogs for those of you who subscribe to our newsletter. So while he's currently undergoing treatment and unable to join us today, he sends his best greetings to each and every one of you. We certainly all wish Wayne's strength and resilience during this difficult time. So for today's webinar, as we all know, navigating the world of fatty liver disease can be a very daunting task, especially now with the new and emerging medical terms and classifications. So the purpose of today's webinar is to simplify and clarify the new nomenclature, NAFLD, NASH. Our goal is to provide you with a transparent understanding of what these terms signify and how they can influence your health journey. We'll also dive deep into the evolution of these terms, unpack their clinical importance, and discuss the potential impacts of the updated naming conventions on diagnosis, treatment, and overall patient care. So our aspiration is to really arm you, whether you're a patient or patient advocate, with the requisite knowledge to have informed discussions with healthcare providers and make confident decisions about your liver health. Next slide, please. So before we begin, I'd like to draw your attention to this slide on the screen. Please take a moment to review the disclosure and disclaimer statements. I think it's crucial for all of us to be on the same page, understanding the scope and intent of the information shared today. So I'll just leave the slide on the screen for a few more seconds so you can read the content. Okay, without further ado, I'd like to hand it over to my colleague, Dr. Niraj Mistry. I think many of you are familiar with Dr. Mistry. He's our Chief Medical Officer at the Fatty Liver Foundation. Dr. Mistry will go over the learning objectives for today, guide us through the agenda, and introduce our speakers. Dr. Mistry, over to you.
Thank you, Henry. And I got to remind the team that they got to change my picture. I've become a bit more hirsute since then. So welcome everyone to this webinar. This is part of the mission of the Fatty Liver Foundation to keep our patient community informed, particularly as there's changes in the medical and scientific field, and we want to make sure our patients are up to date on the information, and most importantly, put it across to our patients in a way that's understandable and simplified for that. So for this webinar, our learning objectives are to understand and update the terminology of NAFLD and NASH, understand the clinical implications of these terms for diagnosis and treatment, which includes screening, engage in informed discussions with healthcare providers about liver health, and recognize the significance of the new nomenclature in patient advocacy efforts. I mean, at the end of the day, what does this mean to someone as a patient? And what does this mean to someone who's at risk of developing these diseases? And so that's what we'll be going through. Next slide, please. Okay, so our agenda, we'll be going through the terminology, the past terminology, and we'll go through the new terminology. We'll get a patient perspective from our dear friend and colleague, Jen Jones. And then I'll go into some of the implications for our patient community, and then we'll have a good chunky question and answer session. People can send their questions through the Q&A chat box, as well as the chat function on this webinar. All right, should we now dive into our first presentation? We're delighted to have Dr. Ranella here with us on this webinar. She's a professor of medicine at the University of Chicago Pritzker School of Medicine and is the director of the Metabolic and Fatty Liver Program. Her focus is in clinical research in the area of NAFLD and NASH, both before and after liver transplantation. She was actively involved in the American Association of the Study of Liver Disease, AASLD, where she's the counsel at large on the governing board, and she's also the author of the practice guidance for NAFLD and the chair of the practice guidance committee. She was very involved in the NAFLD NASH nomenclature initiative, and she was the lead author on the consensus statement. So everything you were afraid to ask about NAFLD and NASH, this is your opportunity, and you'll hear it directly from people who were, from Dr. Ranella, who was involved in this. She also has a national leadership role in the NAFLD, including the chair of AASLD NAFLD Special Interest Group, and is the chair of the NASH Task Force. So certainly about as good or the best credentialed person to speak on this issue. And we're delighted to have you here and now consider you an official friend of the Fatty Liver Foundation. Over to you, Dr. Ranella.
Thank you, Niraj, and thank you to Henry. And I'm very sorry to not be seeing Wayne today. And I really appreciate the opportunity to speak to you, because at the end of the day, what we want to do is raise awareness and bring better care earlier to people afflicted with this condition. So with that, I will ask for there you go. Thank you. Okay, so just as an overview, this is a disease that is extremely prevalent, not just in the United States, but globally. And now the global prevalence is about 30%. So massive. It's extremely prevalent in areas like the Middle East, in South America, Central America, as well as the US and Europe. This is something that is increasingly leading to problems. It is a major cause of cancer-related death actually across the world, and in at least in the US, which is what we're going to focus on a little bit today, is something that presents very, very late. It's fairly indolent in the sense that it doesn't really produce a ton of symptoms. So this is something that we need to focus on, specifically educate and raise awareness for. So there are many associated risk factors, and as I hope I will convince you by the end of the webinar, the name non-alcoholic fatty liver disease has many issues, but one of them is that it doesn't actually tell you what is wrong. It tells you what it's not. In fact, it's actually, I would consider to be pejorative to people with alcohol-related liver disease to focus on that aspect, because it's actually not even true for many people. Of course, it has a strong link to weight, especially central, like weight in the abdomen, and type 2 diabetes and other abnormalities, which we'll go through in a minute. Next slide. So one could say, well, we're really going to decrease awareness if we do this, right? This is, I think, a very telling slide here. So as you might imagine, we have about 300 million people in this country, 330, and about 100 million are estimated to have steatosis or fat in the liver. So this here is a heat map of ICD codings, and of course it's ICD for NAFLD and NASH. And you can see here that, about 61% are in PCPs, 15% are GI Hep, and very, very few are coded by endocrinologists and hepatologists. Next slide. But here you can see that if you take the overlying risk factors that will significantly increase the risk, which we would refer to as implied diagnosis of NASH specifically, you can see that is closer to greater than 16 million just by coding inference alone, and 97% of these patients are in primary care, and we don't see them. They are hidden. They are under the radar. Next slide. So as I mentioned before, this is the most rapidly growing indication for liver transplant. Along with alcohol-related liver disease, it's rising and somewhat in parallel, but if you actually just look at the last 10 years, the fold change in liver disease requiring liver transplantation in people with steatosis, steatohepatitis is 5-fold up. So very, very significant increase, and we should be concerned about that. Next slide. This is, don't get stuck with all the details of this, but basically the main concepts on the left are that the more advanced scarring you have, as numbered by F3, is pre-cirrhosis, F4 is cirrhosis. You can see a very significant jump in the amount of probability of having decompensation, meaning developing ascites, confusion, variceal bleeding, things like that. So serious complications, right? And so look at how that Kaplan-Meier curve goes as it creeps sort of upward over time. It's a slowly progressing disease. However, if you look to the right, this is a study put together based on a claims database of millions of people. And you can see, interestingly, that most people are presenting actually with cirrhosis. And in those that don't present with cirrhosis, the likelihood that the rate of first occurrence of a decompensation, meaning bleeding and confusion, ascites, liver failure, is occurring within a year. And if you look at the blue and the yellow arrows, this is where they should be. Okay, so what this tells me is that we are diagnosing people way too late. And when we're diagnosing them, they're either already decompensated or very close to decompensating. Next slide. So there are many barriers to awareness. I think we all are aware of that. This is not a disease that causes a lot of side effects. In some people it does. And of course, many people are fatigued, but unfortunately that's very non-specific. Right upper quadrant pain can be not consistent across patients. And in fact, I would argue it's a minority of patients that will actually complain of this. I think the biggest problem actually is the sort of the cultural misunderstanding of this disease in the healthcare community. So there's a constant minimization of the consequences. And I cannot tell you how many times I've heard, oh, I've been following my provider for 20 years. I've known that I have fatty liver, but I was just told it's just fatty liver, so there's really nothing to worry about. Well, the problem is of course, there's a sizable amount of people who this is a big deal, and it could have been, progression could have been prevented. Again, this is related to low provider awareness, also over how you risk stratify. So if you don't have a clear understanding of what causes the disease, it's probably less intuitive to know, well, what are the big risk factors for it, right? There is also limited knowledge over non-invasive assessment tools, which are growing in their availability. And there's a lack of clearly defined therapy. Again, as I'm sure everybody's aware, if your doctor says to you, oh, you just need to lose weight and come back and see me a year, the chances of somebody achieving that are basically zero, because you need to support and help people and understand what their barriers are to weight loss. I mean, it's a lot more work than I think many providers understand or are willing to commit. And then, of course, there's stigma associated with both the terms non-alcoholic, which again, of course, ties to alcohol, which for people who don't drink alcohol, find that they need to constantly be explaining that, but it can also be disparaging to those with alcohol-related liver disease. Fatty is clearly a very pejorative term, and if you like, when in the question and answer, I can mention to you a recent example where I wanted to just hide under a table with something my coordinator said in front of a patient. So it's something just to keep in mind. Next slide. So I'm going to walk you through a little bit the evolution of nomenclature in this disease. So the term NASH was coined by a pathologist in 1980, and this was after many descriptions of the presence of steatohepatitis or steatosis in the setting of people who did not drink alcohol. And of course, the presumption was that they just weren't being truthful. But in 1980, Ludwig finally coined this term and had a very, very difficult time publishing it. He published it in a journal called the Mayo Clinic Proceedings, which is not a prestigious and was not a very prestigious journal at the time. And this has become one of the most cited papers in the field. In 2002, I was at this conference when I was a fellow, actually, and we discussed, well, we need a better name for this. We need a more affirmative diagnosis. But at the end of the day, we really didn't have a good enough understanding of what the underlying pathophysiology is. So we landed on NAFLD because that hadn't been described until then either. And here we were up until 2020. So a group of investigators in the field, which you can see here, Mohammed Eslam, who actually don't know, and I'm not sure what he's done in the field particularly other than this stuff. Arun Sanyal, which many of you may know, and Jacob George, who's in Australia, also has a long history in this disease, came up with what was meant to be a proposal. And as in the international consensus panel that you can see there, I was actually in there. So I know what they did and what they did not do from a methodology standpoint, which I can address if you like me to. But they did bring up many things that I thought were useful. In fact, I agree with that it's important to call it what it is and what it's not. That stigma from alcohol is problematic. It's much more helpful to provide positive diagnostic criteria, and it's important to recognize the close relationship with other metabolic disorders. Next slide. But the issue with this was not just the name. Yeah, you could argue that, yes, fatty is still pejorative, so why are we using it? But really, most importantly, from an impact to the field that could have been very damaging was that they also eliminated the concept of steatohepatitis. And that is really the driver of the disease. It's like eliminating the virus from hepatitis C. So that really, we thought was extremely problematic for many reasons, including for development of compounds to treat the disease. But also they allowed a very liberal use of alcohol, meaning you could actually drink a lot of alcohol and still meet criteria for this diagnosis, which again, you may say that may be reality for a lot of people, but the downside is it will alter the natural history of the disease. It may not. It may alter the way biomarkers are used and the thresholds that we use to define disease. And that is very problematic as we're looking to a very short-term, hopefully, horizon of an approved drug for the disease. Now, this was not something that went down easily. But we had very significant concerns over the validity of the process that was used. Again, the majority of people in the consensus process that I'll go through in a minute were actually part of this supposed consensus group. We needed to better address in a more holistic way stigma and disease awareness. Again, the drug and alcohol, the drug development and biomarker development, I already talked about alcohol. And then we did have significant discussions about what actually does metabolic dysfunction even mean? And we needed it to be something that was, if we were going to change it, to be adaptable to emerging disease phenotypes and subtypes, because there's still a lot to learn. Next slide. So I'm going to go through, next slide. So just to kind of go through what it takes to change nomenclature. So the WHO actually has very specific guidelines on what to do for when you want to change the name of a disease. And there are numerous historical examples for this. And I'm not going to go through all those. It's interesting to read about. But basically, there needs to be accuracy and precision. Medical experts need to be involved in the defining of the disease, as you might imagine, to define based on pathophysiology and our understanding of the disease. Societal perception is extremely important. You can't be marginalizing groups or individuals. There are many examples of this throughout history. Just to give you two, the Wuhan virus, which is what it was very damaging, that terminology to Asian communities. The use of GRID for HIV infection was extremely damaging to individuals as well. Policymakers need to understand the impact of the disease. There needs to be awareness across numerous stakeholders. And for patients, most importantly, it really needs to help them understand their disease and certainly needs to avoid stigma. Next slide. So what we tried to do is develop a broad coalition of experts that representing multiple societies. Of course, we couldn't represent every single society. We tried to start with multinational societies to start, and then asked each of these societies to then nominate individuals. These included also members of the endocrine and diabetes societies, pediatricians, several patient advocacy groups, both in the United States and primarily in Europe, although advocacy groups were also invited in Latin America and Asia, but we didn't get very strong engagement. And then very importantly, we engaged methodology and consensus development experts to help us with this process, to make it as transparent and well done as possible. Next slide. So we sought to address the following questions that were lingering based not just on NAFLD, but also because we had, if we were going to do this, we wanted to address as much as we could. So firstly, what are the current issues with the nomenclature and can they be addressed? What's the importance of steatohepatitis in the disease definition and clinical trial endpoints? How should we account for the role of alcohol, or does it matter? How might the impact of disease change awareness, clinical trials and regulatory approval pathways? That, of course, is hypothetical. We would have had no idea to really know that, but that's something that we certainly talked about throughout the process. And if we do have a new name, can this alternate name reduce heterogeneity and allow for future advances in the disease? Next slide. So we had a very broad coalition, as I mentioned. We had 264 nominees, and we nominated them, or the associations nominated them based on their proportionate association member size. 56 countries are represented in this process. Next slide. This is our steering committee. There were 36 of us, including some patient advocates. Wayne, you can see right there, Donna Cryer, and others, actually, Robert Mitchell-Thane. There were a few others as well. But this was other than the patient advocates and representatives. This is a group of highly skilled researchers with actually almost 1 million citations between them, and actually well over 4,000 publications in this particular field. Next slide. We defined a priori, meaning before we did this, it was important for us to decide what consensus was going to look like. Of course, we all want to see 90%, 98% consensus, but the truth is that is not achievable in a disease or in a dilemma that is highly controversial. So we decided on a supermajority before we started. This slide also summarizes the 4 rounds of questions that took place over almost a 3-year period. And you can see that over time, the number of questions evolved. These were modified based on the comments that were received for each round, and 2 in-person discussions that were held to discuss between round 2 and 3, and then between round 3 and 4. Next slide. So where we ended was the following, and I'll start kind of explaining sort of how we got here. So one thing we wanted to do is NAFLD is sort of the umbrella term for the disease, in the sense that within it, we still consider other causes of liver disease to be kind of part of NAFLD, and we feel the need to say, oh, but it's not this, and it's not this, and it's not this, and it's not this. So we thought, would it be more useful to have an umbrella term that just basically encompassed everybody who had fat in the liver? And then from there, we broke into what the actual cause of the disease was. And so we ended with steatotic liver disease. There were other, it was numerically, there were 3 things in the final running, and that was steatotic liver disease, fatty liver disease, and lipogenic liver disease. Steatotic liver disease was numerically the highest. I think it was 48 and 46% for fatty liver, and the rest was lipogenic, a small fraction. But the committee met and decided that because of the stigma associated, even though it wasn't a big difference, if you added the first and second choices, we had to numerically rank the choices, 95% of the respondents chose steatotic liver disease. So we went with that, and that then dictated everything else that came after it. In about round 3, the decision was made to include the term metabolic despite its downfalls. Why? Because even though it's something that's difficult to articulate exactly what it is, because a lot of biology is metabolic or metabolism, it really gets the point across of why patients are accumulating fat in their liver. So we ended with metabolic dysfunction associated steatotic liver disease, or MASL. And from there, metabolic dysfunction associated steatohepatitis. Now, those are, of course, a major mouthful. And I hope that someday we'll end up with something like PDF. We may not know what PDF stands for anymore, or BMW or M&Ms, but the acronym is hopefully will be something that people just get used to over time. Importantly, recognizing that alcohol is a very significant disease accelerator, not just in MASLD, but also in other causes of liver disease, we thought that it was appropriate to include a group of patients who met criteria for MASLD, but also drank more than is allowed in that definition. So more than 20-30 grams for males and for females and males respectively, up to a limit that was previously thought to be moderate alcohol use. Now, there's significant discussion about the damaging effects of even lower levels of alcohol intake, but this seemed to be of course, over what people should be drinking, but a group of patients that we all see all the time and were not being addressed, not being studied, not included in trials, and really we don't have a great understanding of their natural history. And then in gray, you can see all the individual causes of steatosis in the liver, which we can go through if you wish afterwards. Next slide. So we've provided several diagnostic tools for on our AASLD website and other places to sort of help guide providers. So starting with steatotic liver disease or steatosis suspected due to an aggregate of cardiometabolic risk factors like diabetes, hypertension, et cetera, or because elevated liver enzymes are unexplained. There are many ways to sort of enter this, but then asking the question, are any cardiometabolic criteria met? And I'm going to show you what those are in a minute. If the answer is yes, are there any other explanations for steatosis? Like, does somebody have a certain type of hepatitis C, or does somebody also ingest alcohol above the limit? If the answer is yes, then we're looking at a combined etiology like MET ALD, depending on the extent of alcohol, or other combined diseases. And if not, then it would be designated as just pure MASLD. If there is no alcohol intake, then cryptogenic SLD, recognizing that some patients before they develop, have steatosis before they develop complications, could also be in that group and need to be reassessed. And then again, other causes over to the right. Next slide. So these are the cardiometabolic criteria. This is looks more complicated than it is. Basically, you need to meet, if you look at the left, those are the adult criteria. Basically, in the presence of fat in the liver or suspicion of fat in the liver, you need to have extra weight in the abdomen adjusted to ethnicity, pre-diabetes or diabetes, high blood pressure, high triglycerides, or low HDL. These often actually go together, or treatment of any of those conditions. So it's purposefully actually very, very broad. The reason why we did that is for a very specific reason. We did not want to exclude people that were being considered in the NAFLD umbrella because it would change the way we can interpret, 20 some years of natural history data, response to treatment, et cetera. So that was the reasoning for that. Next slide. So with respect to practical application, this is going to really be a grassroots effort. We are doing as much as we can on a sort of high level. We're working with government organizations, we're working with medical associations, but really it's through things like this and partnerships with patient advocacy organizations that we can sort of succeed in increasing disease awareness and assist in implementation. Next slide. So this is actually something that I've developed along with Michael Charlton and Stephen Harrison. I wanted to just share it with you because I think one of the biggest limitations with this disease is that patients, we're not going to get anywhere by just educating providers. That's not going to work. We've been trying to do that for quite a long time, and it's not enough. So I think we need to go directly to patients and to the general population and educate them about what this disease is, how they might be at risk, so that then they go to their provider and say, hey, what I think I might have MASLD or NAFLD or MASH, and this is why. So this website is something we developed. It just recently went live, and it's in its infancy. And if anybody wants to look at it and give me their feedback, I would greatly appreciate it. But the intention over time will be to create an interface where patients are able to log in, assess their liver health, whether or not they have blood tests. Next slide. And assess their risk in a fairly simple way. So we have links to a short healthy eating index that will then tell you a little bit about your dietary composition. It will link you to a group of nutritionists and dietitians that can help you on a ongoing basis, because insurance tends to not cover that. That's a separate company. I think they charge about $40 a month for their services, but it's a really cool service. And then also to sort of gauge your risk. If you don't have liver enzymes, you don't have blood tests, you can use a simple health meter to just gauge your basic risk. And then you can also calculate a FIB4 if you have access to your blood tests. And this then gives you a basic risk gauge, and then you can click to get a PDF. Next slide. And this printout will tell you is something, my idea was that you take this and you show it to your doctor and say, hey, my FIB4 score is 2.86. That is not great. Can you tell me what steps I need to make? And we basically walk them through what the next steps are that need to happen. And we'd like to ultimately link to providers in the patient's area, but we haven't gotten there yet. Next slide. So we have multiple ongoing implementation efforts. We have a living guideline that's being developed, a compendium that I just finished last night and will be attached to the AASLD guidelines, decision tree infographics, an ongoing campaign to increase awareness and adoption, and then multiple stakeholder meetings. Next slide. So now specifically, we've been meeting with regulators, members of the pharma industry, in order to ultimately change billing and coding, because that's really what we will need to completely implement this. Next slide. We've had meetings with the FDA. This is just a screenshot from a recent FDA meeting. The FDA is completely on board with the nomenclature, and we've been working with them. Again, their biggest limitation is going to be with the drug approvals, what to do until the ICD coding is changed officially. Next slide. We've also met with members of the World Health Organization at a meeting. I was at a meeting for the World Health Assembly where we met with many health ministers and the head of the non-communicable disease branch, which is what we need. NAFLD actually isn't even a consideration there. So we're trying to enter also with the new nomenclature and finally be on the map at the WHO. Next slide. So as far as key takeaways, we need to continue to respect sensitivities. This is not an easy thing for many people. We have numerous opinions that of course we needed to consider, but really at the end of the day, the goal is to avoid stigmatizing language, and hopefully with the new nomenclature, give a positive name and an inherent or intuitive understanding of what causes the disease, so that we can then identify who's at risk. The staging and severity of the disease have not changed at all. So this will not change, how we interpret clinical trials. It's not going to change how we risk stratify patients. With respect to clarity, the new term doesn't change the nature of the disease, which I've shown you, clinical studies or any testing that's been done, and it provides a more inclusive name. And then Met-ALD, to me, is the most exciting part of this, because it is a disease that is not, a group of patients, that is not studied. So this is exciting. I'm actually already seeing companies interested in managing and tackling patients with this moderate high alcohol intake in the context of MASLD. So I think with that, that's my last slide. And this is just to show you, we have almost actually 100 organizations now that have endorsed us. So we're very, very honored about that. And then now that is my last slide. So thank you very much for your attention.
Thank you, Dr. Ranella. And I think that's a great segue into our patient perspective on Met-ALD. And Jen is a remarkable survivor of severe interpersonal violence. She faced complex PTSD, leading to her alcohol as a coping mechanism, like many victims who are exposed to this sort of trauma. Her journey took a critical turn at the age of 46 when she was diagnosed with alcohol-induced hepatitis and decompensated liver cirrhosis with a daunting 30% survival chance. During this time, the support of a loyal dog gave her the will to push forward. This experience became a pivotal moment, helping Jen rediscover her purpose in life, ensuring that no one feels alone in their struggles. Today, free from interpersonal violence since 2013 and sober since 2018, Jen combines her educational background, business acumen in aerospace government contracting, and personal experiences to make a difference. In March 2023, she founded a nonprofit dedicated to aiding those diagnosed with ALD. With her leadership, the organization strives to help individuals with ALD and METALD find purpose and joy, proving that everyone deserves a fulfilling life. Please join me in welcoming the resilient and inspiring Jen Jones, who will talk about a patient perspective on METALD. Jen, over to you. Oh, by the way, I'm inspired every time I read or listen to your story. Oh, Jen, you're on mute.
And thank you for telling me I'm on mute. So thank you, Niraj, for your kind words. And thank you, Dr. Ranella, for the comprehensive presentation about the new nomenclature. I am so eager to start disseminating this information. I've already talked to my hepatologist, actually, and I've already started spreading the word. So, and a heads up to everyone, please read the information that are on the slides, as I will be talking about how my experience relates to them and not reading them out loud. Next slide. As Niraj mentioned, today I am 10 years safe from severe intimate partner violence, and I'm 5 years sober from alcohol. My life-threatening diagnosis left me more afraid than I was when staying in 4 domestic violence shelters because of an abuser who stalked me across 5 states. But my shame about my disease kept me too embarrassed to talk with my family. And many times, and I know some other people felt this way too, I thought I'd be better off dead. As Niraj said, my dog Orion saved my life. I needed him and he needed me. If I'd only had a human to share these feelings with that had come out on the other side, alive and with hope. Our goal at Sober Liver is to be that someone, providing group and peer mentor social support while reducing the stigma and shame and increasing the connection and belonging, which is my goal for all people with steatotic liver diseases, aka SLD. Regardless of the toxins that got us to this point, we're all together. So today I want to share how this new category under the SLD umbrella, MET-ALD, will bring us together with the goal of saving lives. Next slide. When first diagnosed with alcohol-associated liver disease, ALD, I began to research liver diseases, and NAFLD always left me a bit baffled. I recalled my sports bar days where some of my friends with high BMIs would eat mounds of chicken wings, burgers, and fries while pounding beers and downing shots with me. My heart started to sink. My abusers isolated me, and, I'd actually lost contact with most of these friends. And I wondered if they were diagnosed with fatty liver, would they be diagnosed with NAFLD based on their self-reported alcohol use? I know the half-truths I told when I was filling out that alcohol questionnaire, and many times I only reported my social drinking, but not my drinking self-medicating. There's a lot of reasons why people aren't transparent about using alcohol. A lot of people fear they could lose their jobs. Other people, they could lose their children. For me, it was that my abusive partner would have another reason to berate me. I believe that the establishment of this new category will change the way doctors diagnose liver disease, and this category will lead to enhanced funding for accurate diagnostic tests and specific treatment for patients diagnosed with MET-ALD. Next slide. This funding will lead to more clinical trials. For the patients in our audience, you may be familiar with having to meet the strict eligibility requirements to become a candidate for a trial. I know I have been ineligible for many. The amount of alcohol used for NASH and NAFLD trials may have made you ineligible, but this next new category may expand the eligibility on both ends of the spectrum to include people with alcohol use for metabolic dysfunction SLD studies and metabolic dysfunction for ALD studies. My hope is that this category will lead to the development of therapeutics and cures that will be effective for the entire umbrella of SLDs and not leave anyone out in the rainstorm. Next slide. We want the sun to shine again for all patients with SLDs. Similar lifestyle adjustments are necessary, no matter where we fall on the spectrum. Our consumption of things like food and drink, we all know should be low in salt and sugar, many times high in protein, and we have to keep our potassium in optimum range. And new research is showing that no alcohol for everyone with SLDs is the safest choice. This includes cooking and baking with alcohol. This took me a while to understand. Did you know it can take more than 2 hours to simmer alcohol out of wine? My SO, who still makes hard cider, believe it or not, uses raisins that are soaked in cider for months. He makes breads and cookies out of these raisins. And I will admit that this is the only time that I have thought about breaking my sobriety of 5 years. Those sweet treats just really trigger me. So this is what I do. I turn on one of my strong songs like Come Back Kid by New Politics, and I start dancing. That's one of my coping strategies. And so I'm curious, after we go into our Q&A, I'm curious, what is your strong song? What do you dance to? I believe that if we unify around stories like these and we share our coping strategies, it'll break both food and alcohol urges, and it will support everyone with an SLD as we are stronger together. And I think that MET ALD can actually be the bridge that connects us. Lastly, as we educate patients like you, it is your opportunity to start educating your providers about this new category. If diagnosed with MET ALD, it is your time to shine, expressing your needs for mental health, food addiction, alcohol use disorder, and targeted support for connecting with people with MET ALD. This way, we can build their capacity to heal and create the sense of belonging. And I think with MASLD, MASH, and ALD now connected under the steatotic liver disease umbrella, with our new friend, MET ALD, we can forge ahead together on a path of awareness, a dry path of awareness, I think I should mention, with no alcohol, increased funding and novel therapeutics. And, yes, I can see through the clouds. I do believe, hopefully, a cure. Thank you, everyone, and I appreciate your time today, and I welcome any questions.
Jen, thank you so much. Really inspiring. I think you and Dr. Ranella nailed it on the importance of MET-ALD in sort of joining or being the bridge between two traditionally very disparate worlds. I'm going to go through my slides quite quickly so we have some time for questions. But I'm just going to reflect a bit more on the impact on patients and healthcare providers. We heard the very robust journey as on how this developed from a scientific point of view, but this was kind of our first reaction as the patient community. There was a whole lot of debate on whether Pluto was a planet or not. And think about if there were aliens living on Pluto and we were going through this debate on how we classify it, would that have any material consequence on those people living or those aliens living on Pluto? And that's how we sort of felt about this when we started on this journey as patients or from the patient community. What are the material implications that this change in nomenclature has on the patient community? Next slide, please. And we were really open to embrace the journey. And so I'm going to dive straight into these opportunities. I just want to make one clear point that I use the word staging, but this is more about the social risk stratification on stage in terms of severity. And I think what's going to really emerge from this is we know that traditionally NASH and NAFLD are a confluence of a whole lot of risk factors, lifestyle factors, as well as comorbidities. And we still have to figure out how the combination of these, together with a person's genetic predisposition, have different tracks or trajectories on how fast this disease progresses. And I think as we now embrace the new nomenclature and sort of more nuanced or specific etiology causes, we'll perhaps get greater understanding or deeper understanding of this. But it's not just a deeper understanding from the patient perspective. This is for providers as well. And we know our hepatologists are stellar and gastroenterologists, but certainly our primary care physicians, with all that they have to deal with, don't have that level of awareness of our specialists. We also now have the opportunity for more refined or better treatment and care, therapeutic and lifestyle interventions as we look at the whole patient and that sort of conglomeration of all these risk factors and predisposing factors. There's a greater opportunity for multidisciplinary care. I mean, just having a pick-me-up song is not something you need a prescription for or needs an FDA approval, but it can have such a huge impact on a person's self-esteem and well-being. And it is through that sort of community engagement, peer-to-peer support, that we can foster that type of holistic care. We have the potential now then to customize patient care. And I use the word potential because we still need to find those therapeutic interventions from a medical point of view that are based on the combination of diseases. And I think they're starting to emerge, particularly with glucose issues and metabolism in that sort of way. And from a patient perspective, I think it's really, really empowering. And we see this in our patient advocates. The more they learn about the disease, rather than just one big label, but the nuanced impact of the disease on them, the specificities that are associated with their condition, it is very empowering, and it sort of induces this health-seeking behavior among our patients. When I was in clinical practice, I used to just be enthralled when my patients used to come and knew more about a disease than I did because they went and did their research around it. I think another thing we realize is that this acknowledges the realistic multiple risk, multiple causes in patients' lives. Our other mantra at medical school used to be that patients don't read the textbook. That's because real life doesn't live according to the textbook. And so it promotes an understanding of this milieu of comorbidities and the combinations that result in this disease. So with that said, next slide. While this now starts acknowledging that there's many causes or etiologies, from a patient perspective, the journey is a common journey. And if we go to the next slide, we show that the key intervention when we looking at all of these diseases, Tiffany, on the next slide, is this lifestyle approach to managing disease. And this is about weight control and caloric restriction, the importance of alcohol, exercise, alcohol use in moderation, and sort of dietary adjustment. So all of this is really, really important. And the use of medicines can be a tremendous complement to this lifestyle approach. And I think increasingly we're understanding in medicine that it's not just about taking a pill. There is no silver bullet, magic pill cure for most things, but we have to address the patient as a whole. And I think when we look at the journeys across all these various subcomponents of NAFLD and MASH, this is what we see as the common element. Next slide, please. And so in conclusion on the patient perspectives, what we really want to always emphasize is all along the way, patients have to be worked with. And this comes across from research to policy to programs. And I think this process that was outlined in on the nomenclature change was a wonderful example of how patients were involved. And in order to do that, we have to make science and medicine much more accessible to patients. We have to design services and interventions from a patient's perspective, not from a provider or payer perspective. All too often, I've heard my colleagues say, well, I asked my patient to to lose weight, and a year later, they haven't lost weight. Well, that wasn't the right way to put the message across or to offer support. And the same thing with quitting smoking or reducing alcohol intake. Looking at the holistic needs of patients through multidisciplinary care, we've talked about that. And then finally, dismantling stigma. I think all too often it was always about placing blame on someone. And so this whole notion of it's not our fault, but it's our collective responsibility. And this can be applied to so many societal challenges that we face together. And this has also been one of the resonating quotes, which comes from an African proverb. If you want to go quickly, go alone. If you want to go far, go together. And this is certainly a journey that we have to go on together for the long run. So that's it from my point of view. And we can now go into the question and answer session. And Dr. Ranella did answer a question on the chat box, but if I can ask her just to sort of expand on that, which is this whole category of NASH, which is called lean NASH, which doesn't have the obvious clinical or physical appearance that might sort of alert someone to having risk.
Yeah, thank you. That's a great question. So we like to avoid the term lean NASH, many of us, because it doesn't really help us. The truth is, most people with what we would characterize as lean NASH, meaning they fall below the BMI threshold, have some central accumulation of fat like around their organs. This is very often very sort of concentrated in certain parts of the world and in different ethnicities. So, for example, we may see that much more in Asia, in certain parts of the Middle East, but more so in Asia. So that being said, those patients who have an accumulation of fat around their organs are metabolically unwell. They may not have overt diagnoses, but many of them actually do. So if you do a fasting lipid profile, or you do a glucose tolerance test, which is sort of a test for prediabetes, you might actually find it. And I would argue that if you don't find it, and you still have steatosis or fat in the liver, then I think we need to look for other causes that are sort of the zebra causes, right? Some of them can be related to your dietary intake, perhaps because you have a genetic predisposition. There's a gene that increases your risk of developing fat in the liver. So that could be it. You could have a more unusual genetic cause that itself causes fat to accumulate in the liver. You could have other unrelated diseases that manifest with fat in the liver. And that's hopefully what your doctor will do, is make sure you don't have these other things. But if you don't have any of those other things, and there's been a very thoughtful assessment, and you still have fat in the liver, but nothing else, the good news is the likelihood of you having scarring and damage at that time is just extremely teeny. And so what I would recommend for those patients is that they be reassessed over time, because that may change. So hopefully that helps.
Absolutely. And you know, the Fatty Liver Foundation, we're working with a group from MIT on looking at a risk stratification model. And it's incredible, as we're developing this model, we're looking at all these factors, and race, ethnicity, together with cultural practices on the diet that types of people eat, etc., together with those normal, or I when I say those commonly identified indicators of risk. And it's turning out to be quite a composite, quite a comprehensive model for us to try and pick up early those people that might be at risk. Jen, did you have any questions?
Actually, I thought Dr. Ranella did a fabulous job in describing what MET ALD actually is. I guess my biggest question would be, how how are we going to diagnose? Is it going to be, are we going to be trusting people's self-reported alcohol use, or are we going to be looking for other, as I mentioned, hopefully diagnostic tests to determine where people fall on that spectrum?
Yeah, that's a great question. I mean, I think maybe to start, maybe I didn't emphasize this enough, because there's been a lot of discussion with the alcohol community about this. And interestingly, they're upset because, you know, we are sort of taking out, we're obviously not taking alcohol. The whole point of this is that we want to elevate awareness of alcohol intake and the cardiometabolic risk factors. And most people with ALD actually have cardiometabolic risk factors, but they're not really being managed specifically. So I'm hoping actually even on the alcohol side that we see more attention and interest in that. So Med-ALD, in my mind, is kind of a spectrum that doesn't really have specific boundaries. And I know that sounds funny for me to say that, but it doesn't really, right? Because it's all about recognizing two different major sources of injury or things that basically will hurt your liver. As far as diagnostically, the diagnostic dilemma can be more on the alcohol side. You know, as Jen mentioned, there's a lot of shame and discomfort with sort of talking in a frank way about alcohol intake. And I would say, and I don't know if this is true, and maybe this is not true, but I feel like, at least certainly in some cultures it is, that women have an even harder time saying that, because it's not as culturally accepted, I guess, or something like that. So that can be a major barrier, right? So we do have biomarkers for alcohol intake. I mean, I would like people to just be honest, because that's how I can help my patients, is if they're honest with me. And I hope that, I'd like to think my patients are generally really honest, because I'm very non-judgmental, and I'm here to help shepherd them to health, basically. So that would be the ideal. But we do have biomarkers of alcohol that can tell us about recent alcohol intake, and we have biomarkers that can tell us about general overall consumption over the preceding month. But, you know, they're not great yet. They're not perfect yet, but we do now have some tools. So I suppose we do have a way of diagnosing Met-ALD in somebody who says they don't really drink very much at all. However, wouldn't it be not better if people just felt less bad about just being open about it? You know, that would really be the ideal. So I don't know if I answered your question. That was a little convoluted, but
it does. I suppose one of the things that I think about is, how do we reduce that fear, right? How do we reduce that fear of the patient? You say you're non-judgmental, and I believe you, and I believe that everything that you say about, you know, that you're going to be open and you're there to help them. But I do know there's that fear component of other things outside of you, right? Which is their family, their jobs, their friends, their children. And how can we begin by, maybe, I don't know, this is just an idea, not starting with this questionnaire, but starting with some motivational interviewing,
yes,
to, you know.
Yeah. You took the words out of it.
Yeah. And that way we can take, you know, that fear away of that questionnaire, and just say, this is a safe way, that you're in a safe place, and you're not going to be sent to a 30-day rehab after we have this discussion. It's just, I want to be able to assess your health as best as possible. And if we could get that out there, I think that would be so helpful.
No, that's actually a really, really good point. And just to be clear, I don't give people questionnaires. Okay. So I ask them, I talk to them in a very sort of matter-of-fact way about their alcohol intake, their pattern, like what, you know, and then if I start to sense that it's something that's going to be harmful. And by the way, I didn't show you a slide on this, but if you have extra weight in your belly, the damage from alcohol is like 4-fold higher. So you have to be very mindful of that. And so I often, almost every patient where I have a conversation specifically about that synergism and how, you know, anyway, so just, I try to take some of the blame away, because it's really, you know, what may be okay for your friend is not okay for you, right? Because of your other risks and stuff. But anyway.
So I think that's great. Oh, I'm sorry. I just wanted to say, if we could get that down to the PCP level, then we'd be stellar.
Yes.
And this is a challenge across many parts of medicine. When we look at the average doctor-patient interaction of 6 to 8 minutes nationally, to build that trust and that rapport is challenging. I want to take one more question, and I just want to also sort of consolidate a response where we have the opportunity now by putting a lot of these diseases under one umbrella, to start dismantling stigma associated with a particular cause. So while we have those tracks on causation, we also, by having an umbrella term, can start sort of breaking down the stigma. But so we covered a lot on the alcohol side, and I think that association and the 4 times increased risk of alcohol damage with abdominal fat or fat accumulation is a very important point. But this question refers to, weight loss, and particularly now when we're looking at the semaglutide revolution that seems to be happening. Mm-hmm. How does that sort of medication have a role to play when it comes to this sort of common etiology of fat for whatever reason that predisposes to MAFLD and MASH?
Yeah, so that's an important question. Of course, I think it's hard to even be awake in this era and have not heard of those medications, because they're really so pervasive. So in most instances, anything that leads to weight loss will improve diabetes, insulin resistance, high blood pressure, and it also improves steatosis in the liver. It reduces fat in the liver very significantly, particularly if it's maintained. So based on that logic, there have been studies that look specifically at MASLD and MASH and done trials where patients were treated with these medications. And what you see is a very dramatic reduction in steatohepatitis, which is what is driving the injury of the disease, the scarring, and what ultimately could lead to cirrhosis. So that's very wonderful, in addition to the fact that some of these medications, not just semaglutide, but others as well, improve long-term survival, cardiovascular risk. So those are important medications or therapeutic approaches, period, because they improve cardiovascular health and life. However, specifically in this disease, what we have not seen is an improvement in scarring related to these medications. And while it may be a function of time, like as in if you lose, say 15% of your body weight with semaglutide or retatrutide or tirzepatide or any of those medications, you may find that while at the beginning you may not have an impact on scarring, you will in the long term. And the long term is really what we care about, because the scarring is what gets you cirrhosis, it's what gets you liver cancer, it's what gets you liver failure. So that's important. So we don't know yet if those medications do that. And that's critical, actually. But hopefully we will, because there are studies ongoing that will hopefully answer that question in the next couple of years.
So that's excellent. And it ties to the last question. And I hope everyone forgives that we might run just like 5 or 6 minutes over, which is, what about medications that can cause weight gain, fat redistribution, everything from chemotherapeutic agents to HIV medicines? So we often talk about the external risk factors and the social risk factors, but what about medications themselves?
Yeah, that's a great point. So I will say, just quickly to address your first point about redistribution. So that would be things like the glitazones, like pioglitazone, that improves metabolic health, improves long-term survival, and reduces fat in the liver, even though it causes net weight gain. Okay, so that there are certain drugs that's not a problem. But there are drugs that increase appetite and hunger. There are some of the anti-psychotic and antidepressant agents that can do that. That can cause worsening of fat accumulation in the liver. HIV and HIV medications are of particular concern sometimes because they cause what we call lipodystrophy, in a sense, where you get this accumulation of fat just in the belly and none in the legs. I'm sure we've all, either we look like this or we've had people that we know that have been like this. So that type of pattern of fat distribution is damaging from a heart perspective and from a liver perspective as well.
That's very useful information. So I'm going to hand over to Henry to offer closing remarks, but a few points I want to make. One, this webinar will be recorded or is recorded and will be put up on YouTube, on our YouTube channel. In addition to that, you can get more information on many of these topics on the Fatty Liver website. Please sign up to the Wellness League, and you can also find information on that, including which we'll be working on to put a list of clinical trials that patients can get involved with as well. So with that, thank you for the attention. And Henry, over to you for closing remarks. Thank you so much, Dr. Ranella and Jen.
Thank you very much.
Thank you, Niraj.
Jen, you are so inspiring.
Oh, thank you so much, Dr. Ranella. I
You are
appreciate that.
so inspiring. So I'm happy that I met you.
Me too.
Thank you. Yeah.
Likewise, I should say.
Yeah, we just need more people. We need more people like you, honestly.
Well, thank you. I'm looking for them. So if anybody is on this call, look me up.
Yeah. No, I will do that. And then do you through your organization so I guess I could through the website I can refer people as well, right? I guess.
Yes. Yeah. And let's set up a talk later too.
Yeah. No, let's do
Okay.
that. Let's do that.
Right.
All right.
Absolutely. So thank you again, Dr. Ranella and Jen, for sharing your expert insights. I wanted to also thank all of the participants, and just to remind for those of you who are planning to attend the liver meeting, either in person or virtually next month in Boston, FLF will be hosting a community conversation on Friday, November the 10th at 10 a.m. During the session, we'll discuss FLF's pivotal role in the transition and implementation plan related to the new nomenclature. So we're obviously committed to forging ahead and ensuring that we serve the patient and patient advocacy community even better. Your insights and experiences are going to be very invaluable to this effort. So once again, thank you all for your time and engagement. Wishing you all a productive day ahead, and hope to connect with you all soon.
Thank you.
Thanks, everybody.
Bye.
Bye.